One concept that I find useful when thinking through this relationship between mental health and spirituality, as we look back over the last century or so of its development, is the notion of the therapeutic culture. The components that would include the notion of technological utopianism, consumerist tendencies and understandings, and the presumption that our commitment is to eliminate all suffering. While some of those may seem appealing at first glance, if we think through them a bit more carefully, I think we realize that the assumptions embedded within them are somewhat problematic. Technological utopianism, as described by Jerry McKinney at University of Notre Dame, is, I think, a compelling notion with regards to the illusion that we have that if we just find enough technology, if we just develop the right technical expertise, that we'll have some utopian reality that will eliminate all of the suffering and all of the inevitable pain that's part of being, I think, vulnerable and frail human beings. This illusion that is frequently part of what we can call a therapeutic culture at times has, I think, perpetuated distortions both for religious and mental health care communities. I think anytime we start to presume that there's a technique that we can use or some sort of maneuver that can be used to in some way alleviate all suffering and take away the pain of our human existence, I fear that we are traveling down some paths that will not lead to a true humane care of those who are suffering, but rather frequently will impose upon them the sense that if they don't make some sort of appropriate maneuver or technique or implement some sort of intervention that eliminates all the feelings of that may be part of their very human existence, that they've in some way fallen short, that they've inadequately lived out their faithfulness, or that they're just not a good patient. I think both healthcare and spiritual communities can, in some ways that are unintended, but will frequently perpetuate and impose greater suffering on those that we're committed to caring for. One particular concern I have is that at times the spiritual care and pastoral care type community can be caught up in that tendency within the healthcare community as well. And if we're not careful, I think we who are interested in these intersections between spirituality and healthcare can start to look toward religion or spirituality as another technique or an intervention to be used to pull out of our black bag, to be used to in some way eliminate the suffering and the struggles that persons are facing. I'd like to challenge us to think, though, about what does it mean to think in a more full and holistic sense about the realities of what patients bring, what persons who are suffering bring to the table, and what informs that suffering in its most full sense, and really what spiritual care has to particularly offer at times that truly is not offered near as well by more standard mental health and psychotherapeutic interventions.
As I came into the VA in the year 2000 with the Chaplain Corps, I thought part of my role in being a Marine and a non-chaplain in this teaching institution was to let chaplains know what it is that they needed to do to survive and to be more effective when working with veterans. If I had 5 chaplains in a medical center, each one of them could give me a different story of what it is that they do. And so one of the things that I taught very early on was try to have a consistent message of who you are as a professional chaplain and what is it exactly that you do. One definition might be, I am a professional chaplain. I provide pastoral care by listening to a veteran's story, identifying areas of spiritual injury or spiritual distress, and from that provide the pastoral care they need to be well and to help with their other injuries. I think the chaplain is very unique in that they bring something to the interdisciplinary team that is not there before. They bring parts of the veteran's story. Rather than looking for a diagnosis, the chaplain looks to hear and to understand the story of that unique person, that individual who has suffered some kind of loss. Everyone in a veterans hospital has some kind of loss. One veteran we had in hospice care was very uncooperative with the treatment team. Did not want to share, did not want to do anything, didn't want to be where he was at. And the issue was, as the chaplain found out, is the veteran missed his dog. Every morning for 10 years, that dog was with him. But since his wife died and since that veteran became sick, he was displaced from his home, his familiar surroundings, but mostly from his dog. So even though he was diagnosed with depression and diagnosed with other issues, PTSD or whatnot, the issue for that veteran was, I miss my dog, and that was lament. And so what happened, the staff downstairs went to the family, where's the dog? And developed a visitation process with the dog coming to the hospice with the veteran, share the bed, be petted, and it made a tremendous difference in the ability of that veteran to actively participate in his treatment plan.
This is a common occurrence I've experienced in 30 years of being a military chaplain, in that we often find ourselves having to define what our role is. But one thing is clear, is that chaplains don't diagnose and we don't treat, we don't prescribe medications. We serve as advocates or a gateway for service members to get the right kind of support before problems escalate. As the principal moral, ethical, spiritual advisor to commanding officers, chaplains enjoy a certain measure of standing and trust because they're on the front line during crisis, and they do provide that gateway to support services. Placement of a chaplain in a unit makes the chaplain a first responder when dealing with combat and operational stress. Because chaplains are organic resources in a particular command, they're bystanders in combat, ready to support service members during very traumatic and stressful times. In other words, chaplains are on the front line whenever any kind of crisis occurs.
When we think of the most important dependent variables or outcomes to be considered in relationship to the work in spirituality and health, I am convinced that we need to be thinking about human flourishing rather than cure. One of the challenges we need to consider together is how to think about human flourishing in a much more communal sense rather than in an excessively individualistic fashion. I think we need to think about human flourishing as being something that inevitably occurs in the context of interdependent lives, as something other than just my own individual experience of some emotion or some sense of an internal process of my own. It's frequently been understood as a very individualistic phenomenon of happiness, contentment, personal sense of well-being, personal satisfaction in some way. None of those are bad things. I'm not convinced that they are the most optimal way to think about and to ultimately conceptualize human flourishing, especially when we're trying to consider the intersections of spirituality and health. I would want to appeal initially that there is a domain of awareness and reality for our patients that has some configuration that includes a tolerance of disappointment, an ability to have an awareness of it's not going to all be like I hoped it would be. There will be disappointment, but yet in the midst of disappointment, I can claim gratitude. And in the midst of those ongoing challenges of life, that yes, I can use tools such as acceptance commitment therapy and evidence-based therapy that a psychotherapist might be able to provide for me, at the same time that I can really do some spiritual exploration with a chaplain, and then that I might even blend those at times in ways that will enhance my capacity to, in a context of anticipation of psychological flexibility, mindfulness practices, and good spiritual exploration and care by a chaplain, actually experience human flourishing.
chaplain, and those who are following this presentation, I assume, are also chaplains, or maybe you have an interest in spirituality and spiritual care. The chaplain goes into the room and immediately looks at the patient's whole gestalt. By that I mean the patient's presentation, their appearance, their affect, their mood, the sound of their voice, the appearance of their bedside surroundings. I look at the walls. Are they bare, or are they filled with pictures and cards, which would indicate that the patient has family or friends? Whether there is family or signs of them, I am looking at what I can see, but what am I also not seeing? I listen to that which the patient is talking about, but I am also listening for that which is unspoken. The chaplain listens to the underlying motif of the patient's story and does a spiritual assessment. In other words, the chaplain assesses spiritual wellness, distress, or injury. Whole person care. Does the patient have meaning, purpose, and hope, or is there a gap there? The chaplain notes spiritual needs and devises a chaplaincy care plan to meet the patient's spiritual or religious needs. Some have asked, how are chaplains unique from other care providers? Understandably, I'm not a doctor. I'm not a psychiatrist. I'm not a nurse. I'm not a social worker. I'm not a nutritionist. What do I bring as a chaplain to the table that is unique from other care providers that I've mentioned? First of all, and other disciplines would also do this, the chaplain views the patient or family as whole persons, not just diagnoses. The chaplain regards the patient as, quote, a living human document, by Anton Boysen, who was the founder of CPE. We'll get to that in a little greater detail later on in the presentation. Being with the patient is not just a visit. It's something a lot more than that. Being with the patient is a spiritual and transcendental experience for the chaplain, even with non-responsive patients. Suppose I'm a chaplain, I enter a room, patient is lying in the bed, and the patient is comatose. Should I spend time in that room when there can be no interaction between the chaplain and this patient in a coma? From the unique chaplaincy experience, just being there with the patient who is unconscious is a spiritual experience for me. And what is it all about? It's about my witnessing the suffering of the patient, witnessing the suffering of the patient. I'm there in the midst of that human being's experience, even though they're not aware of what is going on. If I'm talking to a patient who is responsive and is verbal, I regard the patient's words and story in the narrative ministry as sacred remembrances. They're holy. Comes from Charles Gherkin. With the patient's consent, the chaplain invokes the higher power, whatever that may be, through either formulaic or spontaneous prayer. Mentioning Gherkin, he wrote a book in 1984 which he titled The Living Human Document, Revisioning Pastoral Counseling in a Hermeneutical Mode. Hermeneutical means when you're looking at a sacred text, you're not just looking at the literal text itself on the surface, but you're reading between the lines. You're trying to go deeper, trying to really understand in the most profound way what this sacred text is all about. And Gherkin envisioned the life of the soul as one of continuous interpretation. Quoting from him, a life of attaching meanings to behavior, meanings to relationships, meanings to the self's maintenance of its line of life, and the intimations of the recurrent conflicts of the ego that press upon the soul's struggle with existence. We want to get into the membranes of that struggle. Gherkin states that the self's hermeneutical task or interpretive task is one of holding in tension or dialectical relationship several poles of force and meaning. And that boils down to simple English. That means that each of us have conflicts. We have ambivalence. We have mixed feelings and mixed emotions. Not one of us, I would dare to say, has a one-track mind. There are a lot of competing thoughts and feelings going on in every human being on this planet Earth. Gherkin believed that at the center of any structure of meaning lie the questions of spirituality, of faith, and ultimate purpose. He sees God, and he was a theologian, so he saw the higher power as being a deity. He sees God as a power that participates in all the force and meaning influences upon the life of the soul. So where is God? Is God in heaven? Or is God on earth with us, interacting with us, being with us? Thus, it would seem that when such ongoing interpretation and life review is being done by a person of faith who is searching his or her experience and memories for the presence and purpose of God, then the life review, in other words, one's life story and memories, become sacred, holy remembrance.
One of the strengths that chaplains bring to the table of mental health care is the reality of their commitment to really understanding the full story of the persons who present for care and who are suffering among us. Psychotherapists are committed to that care. The field of psychology is full of good therapists committed to some of those same investments in the understanding of persons. But I think the reality is that one of the things we learn from chaplains is a more broad, contextualized understanding of who a person is that honors and includes their spiritual and faith commitments of their own, from their own traditions and their own backgrounds in ways that we frequently miss within standard mental health care. The inclusion of the contextualized, very textured sense of who a person is through the work that I think is brought to bear by the inclusion of the spiritual dimension and the faith commitments through the inclusion of chaplain colleagues offers an important and vital fullness and capacity to really challenge the tendencies that we have within individualistic psychotherapeutic care at times within the standard mental health community that can offer an opportunity for a more full and complete understanding of a patient in a way than we frequently will get within our standard practices of care in mental health.
In the years that actually followed the establishment of VA chaplaincy in 1945, there was positive interest in what was called the Emmanuel movement. It became later known as the Religion and Health movement. It began actually with Reverend Elwood Worcester, a PhD psychologist and rector of Emmanuel Church in Boston, Massachusetts. His associate and 3 physicians, one of whom was actually Dr. Richard Cabot, who later became known as the father of social work, began a clergy physician psychotherapeutic clinic at Emmanuel Church. And this was back in 1906. Allison Stokes, in his book Ministry After Freud, actually said there was over 100 parishioners that showed up for that first clinic, and in the years that followed, they actually provided care for thousands of individuals who were coming for help at the church. Cabot went on to influence the employment of Chaplain Anton Boyson, who is known as the father of CPE in many circles. Boyson was employed at Worcester State Hospital in Massachusetts, and he went on to establish the first clinical training program for theological students there. It was very highly focused in research. Boyson was very interested in research, and the program trained the leaders for the religion and health movement, including Helen Flanders Dunbar, Carol Weiss, Wayne Oates, Russell Dix, Suet Hiltner, and many others. They, in turn, developed professional and academic relationships with the likes of theologian Paul Tillich, Rollo May, Eric Fromm, and others in New York City. These early leaders of the religion and health movement greatly influenced VA chaplaincy and, to a certain degree, military chaplaincy, and the establishment of the clinical training programs that exist today. The first CPE programs in VA were actually established in the early to mid-1960s and on into the 1970s. They included locations such as Houston, Texas, Bedford, Massachusetts, Martinez, California, and Brooklyn, New York. And these first programs were conducted in affiliation with higher education institutions. For example, the Institute of Religion in Houston, Boston Institute of Theology in Bedford, the Graduate Theological Union out in California, and the U.S. Army School was located in Brooklyn at the time and was associated with that training program in Brooklyn, New York. In the mid-1980s, the first published work of Chaplain Gary Berg and VA physician Elizabeth McSherry greatly influenced VA chaplaincy and the clinical chaplaincy community and medical community in VA. VA actually embraced their work and greatly valued their contributions. They joined the work of Chaplain Dr. Larry Vandercreek, Chaplain George Fitchett, and others from the private sector who contributed to the ongoing research in religion and health. The NCC began to emphasize the importance of research by inviting these professionals to be presenters at our annual Chief Chaplain Leadership Convocations in the 90s. Some of the most important work during this time was actually sponsored by the National Institute of Healthcare Research, led by psychiatrist David Larson. The National Chaplain Center sought out these leaders, along with many other notable physicians, such as Dr. Keith Metter, Dr. Harold Koenig, and Dr. Thomas Horvath, who was psychiatrist and chief consultant for mental health during the 1990s and the early 2000s in VA. We invited them to be presenters again at our national training conferences and developed the initial partnerships with mental health that have led us on to where we are today.
Narrative medicine is to take med students who are training to become interns, residents, and attendings, that if they want to care for the sick as doctors, they must understand that there's more than just diagnostic codes that we put in the computer for Medicare and Medicaid billing. The care of the sick unfolds in stories. The effective practice of healthcare requires the ability of the doctors, and I would also say the chaplains, to recognize, absorb, interpret, and act on the stories and plights of others.
The approach that a chaplain takes when talking to a veteran isn't like many disciplines where you have to ask questions and get answers in order to justify a diagnosis. A chaplain purposely will take a more holistic view and a more patient-centered view. They will ask the veteran, "Hello, Don, how are you doing?" to establish a dialogue and then give the veteran an opportunity to share their story, a human living document, if you will, of who that person is and what that person's about.
Narrative competence is a model not just for what is called logico-scientific medicine, but a model for humane and effective medical practice. It addresses the need of patients and their caregivers to voice their experience, to be heard and to be valued. And it acknowledges the power of narrative to change the way care is given and care is received. What are the elements of narrative competence? Narrative is a source of information that goes beyond the diagnostic differential diagnosis. So narrative is a source of information, but narrative is also an instrument of knowledge, where the doctor and indeed the chaplain see the patient in front of them as a story unfolding before their very eyes.
While the veteran is sharing that story, the chaplain is thinking of what is the lament, what is the most important thing that that veteran is sharing that would give some clue or some indicator of where the chaplain needs to focus the attention. So the story becomes the paramount interaction each time a chaplain visits with a veteran.
Narrative competence serves professional functions beyond the treatment of illness. I mean, beyond the physical aspects of the disease. Narrative competence inspires trust between doctor and patient to promote empathy and relationship and connection between the physician and the patient.
Sometimes a combat soldier or Marine will hold on to things they will not readily share. They've learned long ago to take that information and put it to sleep. And as long as they don't deal with it, it won't hurt them. But as a trust level develops, it becomes easier and easier to share with another individual who I believe understands what I'm going through, who I believe will be there to help me and not try to medicate or not try to, tell me what I should be feeling.
It is indispensable for the professional use of narrative that it finds a clear illustration in the concept of narrative situation. A narrative situation shapes every story by governing who speaks and what is that story about and to whom they're telling the story and at what time and where they are telling the story. The meaning of any narrative must be judged in the light of its narrative situation. And these are the questions that we should ask ourselves. Who is telling it? Who is hearing the story? And why and how is it told?
That's the beauty of listening to the veteran's story, because everything you're getting from that story is coming from the veteran. And you don't have to edit it, you don't have to change it, you don't have to manipulate it to make it fit a particular diagnosis. So for a chaplain, that veteran story is probably the most important part of pastoral care that can be provided. And it gives the veteran the opportunity to share what they want to talk about, not necessarily answer the questions that a clinician wants to talk about.
When the doctor meets the patient in the exam room and is ready to listen to the heart with the stethoscope and to auscultate and to percuss the chest and to get the pulse and all of that we have in physical examinations, there is more, or should be more, that is happening between the caregiver and the patient. And that is the relationality between two persons in that exam room. Narrative discourse is someone telling someone else that something happened, emphasizing narrative's requirement for a teller and a listener, a writer and a reader, a chaplain or a physician or a nurse or a social worker with a patient, and most importantly, a communion of some sort between the two. Ultimately, narrative medicine and narrative chaplaincy both utterly depend on the concept of intersubjectivity. Narrative considerations probe the intersubjective domains of human knowledge and activity. That is to say, those aspects of life that are enacted in the relation between two persons. The narratively competent reader or listener realizes that the meaning of any narrative, instead of being monolithic and hierarchically given, meaning from the top down, meaning is apprehended collaboratively by the reader and the writer, the observer and the observed, the physician and the patient, the chaplain and the patient. And we've heard a lot about patient-centered care. It's no longer the physician being the knower of medical expertise. The patient is the center of our focus, and medical decisions and treatment decisions have to be made in a shared way, which is called shared decision-making.
Clinical pastoral education, CPE, is a process model of education that is student-centered, vigorously reflective, and potentially transformative for those who participate in it. The goal of CPE is obviously professional competence, which includes the integration of personal story, religious heritage, and theological understanding and knowledge of the behavioral sciences. The integration leads to personal awareness, integrity in relationships, and receptivity to diversity. Spiritual care is provided based upon respect for the desires and spiritual concerns of patients and their families. Spiritual care is provided through professional relationships marked by accountability, mutual respect, and clear communication and ethical practice that supports personal and professional integration of care of self and others. So it's not so much about therapeutic technique as it is about authentic presence and genuine empathy and compassion.
How do chaplains hear, or how should they hear and understand patients' stories? Clinical Pastoral Education, or CPE, pays close attention to illness stories surfaced through intersubjective encounter between the chaplain and the patient. And all chaplains who have gone through the CPE process know that one of the elemental aspects of CPE is writing verbatims. The verbatim is a major educational experience in CPE. Verbatim seminars involve a student in CPE presenting a pastoral encounter, or what we might call the narrative, to other students and the CPE supervisor for discussion, both with affirmation and critique. When I say verbatim, I don't mean that the CPE student is a stenographer. It is not literally every word that came out from the patient's mouth, from the chaplain's mouth, and from the family's mouth. The verbatim is the subjective presentation of the visit by the chaplain to the patient, and how the chaplain remembers what was said and what the issues were, and writing it up.
So that when I go back to the interdisciplinary team, I can go back and say, this is what I learned from the veteran at this time. Even though he's here for PTSD or depression, he's really focused on this issue, which may be something completely different than what that person was admitted for.
I have a student in my class this semester who is a military chaplain, and he told a story last week about an event that had happened in his clinical pastoral education training. He had a family whose young son died unexpectedly, and he said that he felt that his important job was to hold a protective space for them in their grief and their vulnerability. One of his most important responsibilities was to evoke the existential worldview or the ultimate concerns of his patients, and to listen to them and to capture their own language of the way they express these concerns, and to put it in the chart so that the patient's views that only the chaplain really has time to listen to could find their way into the awareness of the nurses and physicians and other healthcare workers who are members of the team. My chaplain student also told me a story about a very tragic story of a young 18-year-old HIV/AIDS victim who was being discharged from the hospital, but the chaplains were aware that his own family and religious community and neighborhood had all rejected him, and that he really had no place to go. And being 18 years old, was a legal adult, but still really a child in many ways. And the head chaplain, the chaplains discussed this, and the head chaplain said that it was their job to make sure that he had a safe discharge. And they accomplished that by connecting him with the resources that he needed for housing, for follow-up care, and for a safe place for him to be in the community.
So how can we sum this up? What's the take-home message here? Lack of, I'm going to phrase this as an epidemiologist now in the negative, lack of a loving, meaningful, hopeful connection with God or other people that can motivate us and help us to transcend life's challenges, including physical challenges, health challenges, that this may be literally sick-making for individuals or populations, and that lack of the resources, the religious resources that lead us to feel love and have a sense of meaning and hope and connection and so on, that these things are quite literally a risk factor for mental illness or psychological distress. Phrased in the flip side, faith, spirituality, religion, belief in God are potentially powerful resources for coping with stress and reducing risk, and thus for some of our clients or our patients, our research subjects that value religion, that value faith in their own life, that have a commitment, these things may be sources of health or wellness. It's not for everybody. I'm not suggesting there's no pathway to mental health without religion. I don't believe that. I don't think the evidence suggests that, but for our clients, our patients who affirm the value of religion, who affirm faith in God, who have religious belief, we need to understand that the ability to have continuity in practicing this faith, whether at an inpatient or outpatient setting, could be vitally important in maintaining a sense of well-being. And that in the absence of that, it's really not surprising that people would be in distress. So not only am I suggesting that spirituality is important for mental health, important for preventing psychopathology, for promoting positive well-being, but it also may be very important for those of our clients who are people of faith, religious, spiritual, and are, let's say, hospitalized for physical challenges or for issues that are not necessarily mental health related. If they're in a situation where they don't have access to or continuity in their own spiritual lives, they're removed from their church or congregational community, regular prayer, regular worship service, pastor, and so on, that this can actually lead to additional mental health issues that weren't part of the primary reason that they're receiving care. Because of the lack of access, as I said, to the meaning and hope and transcendence and connections with God and so on, this can actually produce crises of well-being that weren't necessarily part of the original challenge.
Important to consider when we're thinking about the integration of mental health and chaplaincy is the importance of the chaplain who's been trained through clinical pastoral education and other modes of formal, considered thoughtful equipping to serve as a chaplain in a healthcare setting in comparison to those who have not had that benefit of that training. I do think that that's part of where we want to encourage persons who are sensitive and really want to honor the importance of including spiritual dimensions in the care of patients, to be aware that while they might mean well and might intend well, they might easily slip into, at times, usage of what I might call sort of a therapeutic spiritual technique or something, rather than understanding the fullness of what the properly trained chaplain would have to offer in the inclusion of spiritual care in a very full and rich textured way in the care of a patient, but able to avoid the distortions and the sometimes tempting, seductive commodification of spirituality as a technique to be used on someone, like as if it were some sort of medical intervention. The truth is, I think, that spiritual care as part of healthcare is much more distinctive and is a sacred space that needs to be honored for what it brings to bear, rather than thought of as one other simple piece in the black bag armamentarium of standard healthcare. Everyone loses if that distinctiveness and that honoring is not included in the ongoing integration of mental health and chaplaincy.